Good evening and welcome to EKDGCon 2026. I'm delighted to welcome you all to this program wherein we will be discussing lifestyle medicine, and I think this is the first time that we are doing a program which is just about lifestyle medicine. The focus naturally will be a lot on obesity and diabetes related problems, and also problems which arise out of these. And for you, we have got a galaxy of superstars who are going to be talking about not the usual topics, but some unusual topics which we have selected. We have a wonderful array of superstars out here, and you have seen the program leaflet. We will be having time for discussion as well. We will try and stick to time as much as possible, and the chairpersons will be looking after that. But to initiate the whole proceedings and make sure that everything is run according to what we should be running it according to, may I welcome on stage Dr. Nirmala Chakraborty, who will be comparing the entire program. Nirmala, all yours. Welcome delegates. Hope you have a lovely 2 days. Thank you very much.
Good evening, friends. Thank you, Binayak and Shomit and the entire EKDGCon 2026 team for inviting me to take over from here onwards. We are really going to be having some kind of information explosion now and tomorrow also, as far as lifestyle, as Binayak has been saying. This is something I personally feel we always write in our prescription, but do we follow it? Our patients follow it. I mean, when we write diet and exercise and kind of thing, on top of whatever medications we are giving, it's very difficult to follow them up and ultimately see whether they are following this. And this is of paramount importance primarily because on the basis of this, all other medications will work. If you don't follow this, you are not going to win the war of whatever complications you can understand as far as these lifestyle disorders are concerned. So we are going to have Dr. Supratik Bhattacharya. Can I welcome you to the stage, who will be talking from advocacy to evidence-based therapy, because these are the days when whatever we take on should be evidence-based science, right? So Supratik will see us through how these evidences can be percolated as far as our management protocol, particularly in response to the complications of these lifestyle disorders are concerned. So, Supratik, your floor is yours.
Thank you, Dr. Nirmala, and it's a privilege to be here. Thank you, Dr. Binayak Sinha, Dr. Samit Ghoshal, and the entire team. So this is a very interesting topic that had been given. I'll be talking about lifestyle medicine from advocacy to evidence-based therapy, as you just heard. First of all, I didn't know that there was something like lifestyle medicine that existed. It's only when I was actually researching this topic that I got to know there's an association of lifestyle medicine exists. And just to set the context, this is according to ITF, that almost 20 to 79 people, those who are aged between 20 to 79 are living with diabetes, and the number is about 589 million. And by the time it's 2045, this number is going to increase to about 853 million. Now, if you look at the ICMR India database, you see that the metabolic diseases, the prevalence in India is very, very high. And if you consider generalized obesity or abdominal obesity along with diabetes, the numbers seem to be very high. So obesity is a global health problem, and it's a prevalent, complex, progressive, and relapsing chronic disease, and characterized by abnormal or excessive fat or adiposity that impairs health. So if you consider India, the 1 billion people are affected with obesity, and out of that 764 million are adults, and almost 150 million people are adolescents and children. So if you consider those kind of diseases that can be addressed by lifestyle medicine alone, that's the top 10. So you see diabetes, obesity, hypertension, dyslipidemia, MSLD, cardiovascular system, polycystic ovarian syndrome, obstructive sleep apnea, osteoarthritis, depression. So all of these are diseases that can be addressed by lifestyle medicine at large. Now, as I said, I was not aware that there was an entity called lifestyle medicine that was there, and it actually has an association, and there is a chapter in India as well, and they have a structure of the course as well. So they have a very structured program, and anybody interested can visit their website and can become a member and take exams to be a member of this lifestyle medicine. So why lifestyle medicine needs a reframe? Because historically, we only talk about lifestyle as an advice. We don't actually prescribe lifestyle medicine. So we need to get on board with prescribing a lifestyle as opposed to pharmacotherapy, which we do in our routine practice. So if you consider the 6 pillars of lifestyle medicine, they are nutrition quality and caloric balance, physical activity and muscle preservation, sleep health, stress management, avoidance of harmful substances, social connection and behavioral changes. Now, we'll address one by one. So these are the snapshot. So you start with the physical activity, sleep, stress management, social connection, avoid risky substances, and healthy eating. So healthy eating. We have very many trials, including landmark trials like the direct extension trials. And you see that the Predimed trial, which is predominantly Mediterranean diet, reduced major cardiovascular events by 30%. Direct trial, I'll talk a little more in length at time, but it shows greater weight loss and metabolic improvement than low-fat diets. And this, we are talking about really low-calorie diet. And we'll talk about the banes and boons of each of these diets. Then you have the direct extension trial, and we see that if you're following the direct trial, almost 46% achieved remission at the end of 1 year. What are the key mechanisms? Improved insulin sensitivity, reduction in visceral adiposity, reduction in systemic inflammation, and improved lipid metabolism. Then comes physical activity. Do we have any evidence for this? Yes. One is the diabetes prevention program, which showed that lifestyle intervention reduced diabetes by 58%, outperforming metformin. So this was a head-to-head trial where lifestyle was compared to metformin and showed that lifestyle was superior, and it reduced the risk of diabetes by 58%. Then you had look-ahead trial. Intensive lifestyle intervention improved weight, glycemia, and cardiovascular risk factors. Then you have STRIDE trial with 2 hours and demonstrated improvement in insulin sensitivity and body composition. So what is the lifestyle prescription that you give, or the exercise prescription? About 150 to 300 minutes per week of moderate exercise, about 5 days a week. And also you have to prescribe resistance training at least 2 days a week as well. What are the physiological effects of exercise? It increases the GLUT4 mediated glucose uptake, increased mitochondrial function, reduction in the hepatic fat, and improved endothelial function. Now coming to the third one, sleep. So this is again very, very important. The quality of sleep and the total duration of sleep. So it should not be less than 5 hours and not more than 7 to 8 hours. So sleep deprivation and insulin resistance are linked very closely. Sleep restriction causes acute insulin resistance, and sleep heart health study shows that sleep disorders strongly associated with cardiometabolic diseases, and epidemiological evidence shows short sleep, less than 6 hours, increases the risk of obesity, diabetes, and hypertension. What are the mechanisms? It seems like sleep deprivation alters leptin levels. So the leptin levels go down, ghrelin levels increase, so the hunger hormone goes up, appetite regulation is affected, cortisol rhythmicity is affected, and it promotes weight gain and metabolic dysregulation. Fourth one is the stress management, and chronic stress activates the HPA axis and sympathetic nervous system. This is a Whitehall 2 study, which shows that chronic stress linked with increased metabolic syndrome risk, and the MBSR trials, which shows that mindful practices reduces stress, blood pressure, and inflammatory markers. So we know that cortisol is a hormone that is released during acute stress, but if you are under chronic stress, cortisol can put fat in the wrong places, and that leads on to many challenges like insulin resistance, visceral adiposity, systemic inflammation. And stress reduction interventions include mindful meditation, yoga, breathing exercises, cognitive behavioral therapy. Social connect. This is the fifth arm. So Harvard study of adult development shows that strong social relationships predict better longevity and health. Meta-analysis shows social isolation increases mortality risk comparable to smoking and obesity. And these mechanisms include improved mental health, improved adherence to therapy, and reduced inflammatory burden. Avoidance of risky substances or substances of abuse. So WHO shows that tobacco causes more than 8 million deaths per year globally. Smoking cessation reduces cardiovascular risk dramatically within 1 to 2 years after cessation. And alcohol excess contributes to liver diseases, hypertension, and cancer. So that has to be moderated. So obesity as a chronic relapsing disease, we know that it's now termed as ABCD by ACE, which means adiposity-based chronic disease. And there are many factors. There's a genetic, epigenetic factor, environmental factors, everything coming together. And we need to consider this as a chronic disease, and there would be a lifelong treatment for that in the form of lifestyle advices, lifestyle medicine prescriptions, as well as, if required, pharmacotherapy. So neuroendocrine and metabolic dysregulation, adiposity, adiposopathy and insulin resistant, inflammation and ectopic fat deposition, and it requires long-term multimodal therapy. So again, recalling the landmark trials that we just said, where lifestyle has got a major role to play. One is the diabetes prevention study. One is and we had seen that if you are giving lifestyle advices and dietary modifications, you can reduce the risk of diabetes by 58%. Okay, now let's talk a little bit more about the direct trial that we were saying, and you can see in here that the cohort who got a weight reduction of more than 15 kilos from the baseline, and that was about 24%, had a remission rate which was as high as 86%. So this is fantastic. We are now talking about very many molecules which can give you more than 15% weight loss, but we see that in the direct trial that there was a significant portion of the patient, subjects who achieved a weight loss of more than 15 kilos. And this is absolutely fantastic. What the concern is, if you look at the next slide, at the end of 1 year, the remission rate was 46%. At the end of 2 years, the remission rate came down to about 35.6%. At the end of 5 years, which is the direct extension trial, the remission rate came down even further to about 13%. So you're seeing that as the time is going on, the dietary advices and lifestyle is not sufficient to maintain the remission that we had achieved with the kind of weight loss from the direct trial at the end of trial. Any remission at the 1 year was about 11.5%. And at the end of 4 years, it came down to about 7%. So whilst it's a very robust way to achieve weight loss and remission, however, it is very, very difficult to hold on to that weight loss at the end of 1, 2, and 5 years. So why lifestyle programs fail? Lack of structured physician training, unrealistic patient expectations, poor long-term adherence, and absence of multidisciplinary care. But more importantly, there's body's physiology which comes into play, and the moment you start losing body weight and your body weight comes down from the set point, body's, hunger hormones are going to come into play. It's going to start pushing up the body to back to where it belongs. And that's where pharmacotherapy comes into play. And if you combine lifestyle prescriptions with pharmacotherapy, it's can work on the body's set point and bring it lower down, so even if the body pushes it, it doesn't go beyond a certain point. But same with the lifestyle as well. The moment you stop the pharmacotherapy again, the body weight is going to start going back up again. But we do have robust trials showing that it probably doesn't go back all the way to the baseline, and you do get a legacy effect to a certain extent. So one thing I must emphasize, that there is no substitution for lifestyle and dietary modifications that are warranted in the first place. But over on top of that, it might be helpful to have some kind of pharmacotherapy which gives you assistance in lowering down the set point and maintaining it there. So structured obesity clinical model, baseline metabolic risk assessment, dietitian-led nutrition therapy. So you can't work alone. You need to have a robust team in place. Exercise prescription along with dietary modifications is very much essential. And we said we want two components. One is the aerobic component, which makes you lose the calories. And also, so that you're not losing lean muscle, you have to have on board some form of resistant exercises at least twice a week. Behavioral coaching and pharmacotherapy also might be added on to lifestyle modifications or lifestyle prescriptions that you are giving to your patients. So future directions is all about precision lifestyle medicine, body composition guided therapy. So we look at the body composition and see whether the person is becoming metabolically more healthy. Digital monitoring, continuous glucose monitoring guided diet, so that the patient can get a hold on themselves. They can take charge of their diet, and you have to empower the patient to take charge of their diet as well as health. And AI-based metabolic prediction is very much essential. So key take-home messages: lifestyle therapy is evidence-based medicine. It has been around for a very long time. It works. Only problem is that adherence seems to be a key challenge. Prevents diabetes and cardiometabolic diseases, and we do have evidences supporting that. Enhances pharmacotherapy outcomes if you are combining pharmacotherapy along with lifestyle, and should be prescribed as a part of routine care. So just to let you know that there is a lifestyle medicine conference that is happening this year, or last year, and this just happened at Texas. And if you're interested, you can look up the website, and if you want to become a member, I think they have a counterpart in India as well. Thank you.
For the time being, Ms. Rimi Banerjee, you have come a little late, but at least you have reached just in time. So we are going to listen from you nutritional prescriptions matching diet to metabolic phenotype. We know the metabolic milieu has been interacted with different kinds of phenotypes. So this is something which has got direct relation with dietary counseling and dietary management. And Rimi is a known person in this field, and I think she will do justice. But once again, reminding you that time should be honored as well. Thank you. Over to you.
Thank you, sir. So, good evening, everyone. I'd like to thank you, the organizers team of Lifestyle Medicine 2.0, and it's a great feeling to stand before this group of incredible clinicians here at Taj Vivanta. Excuse me, I'm late and I'm just taking my breath. So, today's topic of the discussion is the calorie deficit versus macronutrient targeted diets for MSLD and visceral obesity. So we treat liver, but often we neglect the metabolic fuel driving its inflammation. So now we are moving from the weight loss from metabolic remission. So at first, let us head on the problem, how it works, the pathophysiology of MSLD. So we get to know that the adipose tissue releases inflammatory cytokines, and that can lead to liver inflammation, insulin resistance, and progression of advanced fibrosis. And here comes the therapeutic dilemma. While weight loss is a crucial for MSLD, the optimal dietary strategy remains debated, highlighting the macronutrient composition as a critical research area. To fix that, we should go to the basic math. Is the calorie deficit is the finishing line or the starting block? Let's clarify why the energy balance is the non-negotiable factor for MSLD management. So, here the National Institute of Care and Excellence guidelines that recommends approximately 600 calorie per day deficit for safe, sustainable weight loss that can be 0.5 to 1 kg per week, and this gradual approach minimizes the muscle loss and improve the adherence. And what will be the threshold for this clinical benefit? The weight loss, 7 to 10% of body weight consistently demonstrate the improvements in liver enzymes and reduction of the accumulation of fat in liver, and this threshold represents the clinically meaningful target for MSLD patients. As I said, it's not just about the count but the type of food. If calories are the quantity, macronutrients are the quality. So why do we take the risk of losing our muscle mass if we don't address the carb to protein ratio? So here is the benefits of high protein intake, carbohydrate modulation, and balanced fat profile. The higher protein intake, 1.6 to 2.4 gram per kg body weight during calorie restriction, preserve a lean muscle mass, reduction of inflammation, and reduces the satiety, as well as low carbohydrate diets like particularly ketogenic show anti-inflammatory effects and promote rapid visceral fat loss by reducing the hepatic de novo lipogenesis. And balanced fat profile, the balanced fat comes from 20 to 30% of total calories, with emphasis on unsaturated fatty acid like omega-3, and that can improve the liver profile, liver health, and insulin sensitivity. So to prove this, let's look at the data. What happens when we push the metabolic boundaries? Let's look at the data on how very low energy ketogenic diet and why the numbers ALT, AST, and CRP tells a complete different story. A clinical trial involving 80 obese patients or women with MSLD examined very low energy ketogenic therapy. Participants followed a ketogenic phase less than 800 calories per day with a macronutrient distribution of 30% carbohydrates, 43% protein, and 44% fat. What are the clinical outcomes? The BMI and waist circumference decreased substantially, total fat mass showed marked reduction, and TG level improved, liver enzyme got normalized, high sensitivity C-reactive protein decreased. So what will be the clinical significance? This study shows that very low energy ketogenic therapy has a strong anti-inflammatory effect and metabolic benefits in MSLD driven by the macronutrient composition. So what is the best plan for the plate? We have settled on 35-35-27 split. Here is the clinical breakdown why this specific distribution can optimize the satiety while aggressively targeting the inflammation of liver function. So, the 35% of protein can preserve the muscle mass, reduces inflammation, and increases the satiety during calorie restriction, while the complex carbohydrates or low GI carbohydrates can maintain the glucose level or can minimize the glucose spikes, and 27% fat focus on omega-3 fatty acid can have or can give the anti-inflammatory effects. So in fact, why does this number help the liver so much? Why do two patients with identical calorie restriction gives a different or complete different outcome of liver? So it's not just the calculation or the math, but the biochemistry of lipogenesis. The clinical impact, why macronutrient targeting enhances calorie deficit, protein-induced satiety. As we learned that protein-rich diet increases the feeling of fullness and reduce hunger that support the sustained calorie deficit. That means our patient can stay in their calorie deficit effortlessly. And reduction of lipogenesis, low carbohydrate diets reduces the accumulation of fat in liver or the process of accumulation of fat in liver, directly targeting liver fat accumulation. And the metabolic optimization can be done by the good amount of balanced fat that improves the insulin sensitivity, lipid metabolism, and creating a favorable environment for lipid mobilization. These macronutrient strategies support sustainable visceral fat loss, reduces systematic inflammation, and improve liver histology. Macronutrient optimization is essential for MSLD patients. Now, how do we make this easy for our patient? I hope all my seniors will agree with me that the best diet is that our patients follow willingly and longer period of time. So, how do we translate these complex metabolic goals into a sustainable, repeatable plan to the real world? So, what will be the practical dietary strategies for MSLD patients? Emphasize on whole foods. What are the whole foods? Whole foods mean that needs the minimal processing to eat or to consume. So prioritize lean proteins, colorful vegetables, nuts, seeds, and omega-3 rich fatty acid. And these choices can support the metabolic health and minimize inflammation. Limit refined carbohydrates. As a food safety auditor, I have to say very sadly that every packaged food has minimum amount of sugar in any possible way or any possible form. So we should advise our patient to take the least amount of packaged food or to avoid as much as possible. So refined carbohydrates and eliminate added sugars to reduce liver fat synthesis, focus on fiber-rich whole grains and low GI index options when consuming carbohydrates. Combine moderation with optimization. So we know anything extreme is not good. So 500 to 700 calorie per day restriction should be a sustainable approach, and that can help to reduce the inflammation. Monitor regularly. This is my favorite part, that we should monitor each and everything to our patients. Like I have my team and they help me a lot to do that. Our treatment protocol should be listen first, then assess, then counselor suggest, then monitor and repeat the process again. I think this would be the best option to identify the loophole of our treatment and to get the optimum result from our treatment. So to show you, here is the real patient story. And let's look at the 12-week transformation that shows why this isn't a theory, it's a clinical practice. A 12-year-old man with BMI 38 kg per meter square, diagnosed with MSLD and visceral fat obesity, waist 110 cm, initial labs showed elevated liver enzymes, insulin resistance and dyslipidemia. A 12-week program with 600 calorie per day restriction. He was taking 800 calorie per day and macronutrient distribution was 38%, 35% protein, 35% carbohydrate and 30% fat. So what were the results? The results are 9% weight loss from 120 kg to 109 kg, 15 centimeter waist reduction from 110 centimeter to 95 centimeter, 50% enzyme normalization and 30% the insulin improved the sensitivity. The major point is we can reverse this today. So we have the tool to move MSLD from a chronic burden to a reversible metabolic state. So let's start the discussion on how we can implement this as a standard of care. So this is my last slide. I'll be very precise that this is beyond doubt that calorie restriction is fundamental. A controlled calorie deficit is fundamental for hepatic fat reduction and MSLD regression. Macro targeting precision. So optimize the calorie restriction. We need the macronutrient precision or macronutrient optimization, like we should always focus on high protein, good amount of fat and low GI carbohydrate to optimization of the anti-inflammatory effects and personalized synergy efficacy. Every body is a different type, has a different type, different story. So we need every patient's treatment protocol in a personalized way, because we know liver is a numerous mechanism liver has. So every patient has a different story of their pain, their physiological and psychological. So we should treat them in a very personalized way, not only the dietary pattern but also the lifestyle pattern, and always emphasize on to eat local, seasonal and traditional, and always suggest to communicate in a very strong way to get the optimum result. So thank you for your time and your dedication to your patients and for being such an incredible audience. Thank you so much.
Thank you, Rimi, for giving us an overview of how diet can play a very important role. That is one thing. And I personally feel in my practice it is easier said than done. Okay, so probably we need support from your end or the team that you are having. So can you come over here so that we can have a couple of questions to clarify any point that Supratik has already been spoken to and Rimi has just now spoken. So anybody have any specific question? Be very specific, one-liner, and remember that all the audience might be benefited from that. So very specific and defining questions should be there.
খাওয়ার সঙ্গে স্পেসিফিক করলে গন্ডল পাকাবে। খাওয়ার একটা আর্ট, খাওয়ার সঙ্গে বলতে নেই, খাওয়ার সঙ্গে আর্ট, এভরিথিং ইজ আর্ট। তার মধ্যে খাওয়াটাও ইম্পর্টেন্ট, যার জন্য আমরা বেঁচে আছি। যাই হোক, 35% যদি প্রোটিন খায় আর 35% যদি কার্বোহাইড্রেট খায়, তার কার্বোহাইড্রেট তো আমাদের ক্যালোরি যোগায়, এবার ক্যালোরি শেষ করলে প্রোটিন থেকে ভাঙাভাঙি করবে, আর প্রোটিন ভাঙলে শরীরের ক্ষতি করবে। About 50% from the carbohydrate.
Not 50%. It should be 35-27 protein, carbohydrate and fat.
কারণ আমাদের বইয়ে লেখা আছে, আমরা তাই বলি 0.83 per kg per day হলো প্রোটিন। এবার সেইটাকে অত দূরে নিয়ে যাবো আমি।
হ্যাঁ, তার কারণ হচ্ছে 90% ইন আওয়ার পপুলেশন হ্যাজ সাম অ্যামাউন্ট অফ সার্কোপেনিয়া ইন ইন্ডিয়া। তো ওই থ্রেশহোল্ডটাকে মিট করার জন্য আমাদের প্রোটিন লেভেলটাকেও বাড়াতে হবে। তারপরে যখন আমাদের সার্কোপেনিক স্টেজটা নর্মাল হয়ে যাবে, তখন আমরা আবার 0.8-এ ফিরে আসতে পারি।
কিন্তু প্রোটিন অটো দিলে তো ভাঙবে, ভেঙে তো ক্যালোরি বের করবে
না, এবার এক্ষেত্রে আরেকটা ম্যাজিক আছে।
35% ক্যালোরি কি করে হবে?
এই ক্ষেত্রে একটা ম্যাজিক আছে, প্রোটিন ভাঙতে গেলেও বডি থেকে ক্যালোরি দরকার বেশি। তো সেই ক্যালোরিটা প্রোটিন ভাঙতে গেলে, প্রোটিন ডাইজেশনের জন্য যতটা ক্যালোরি আমরা খরচা করছি, সেই অ্যামাউন্ট অফ ক্যালোরি যদি আমরা কার্বোহাইড্রেট থেকে খাই, ততটা ক্যালোরি ভাঙতে লাগবে না, ফ্যাট থেকেও লাগবে না। তো ইটস আ ব্যালেন্স। আর শুধু ইটস নট অ্যাবাউট দ্য ক্যালোরি, protein is a building block and protein has numerous important role to play. তো সব দিক দিয়ে বিচার করতে গেলে, yes sir, please.
Yes.
Standard recommendation, dietary recommendations by the United States bodies or Indian bodies is carbohydrate should be at least 45 to 55%. There are certain studies or recommendations which are cutting down on the carbohydrate at the expense of protein. But again, it is easier said than done because protein is costly, number one. And number two, if the carbohydrate is complex carbohydrate, it's isocaloric, I think there should not be any problem if the carbohydrate is 50 to 55%, and that's what we are practicing in our day-to-day life.
Yeah, I do agree. Nilanjan.
Yeah, regarding satiety, it was said that high intake of protein decreases satiety, or increases satiety. It causes fullness, and it is also a negative calorie intake. High protein means you are spending more calories for digesting that protein. So how does it cause satiety, increase satiety?
Protein gives us fullness in a very short period of time. That is the number one point, and we are craving less. We will be craving less if we take adequate amount of protein. If we are crave for some food less, we will be in a budget, calorie budget যতটা আছে ততটার মধ্যেই আমরা থাকবো। এটা একটা পয়েন্ট। আর প্রোটিন যদি আমরা একটা মডারেট বা হাই অ্যামাউন্টে নিই, সেক্ষেত্রে আমাদের ফুলনেস থাকার ডিউরেশনটা অনেক বেশি থাকবে ইন দ্য কম্প্যারিজন অফ ফ্যাট অর কমপ্লেক্স কার্ব। ফ্যাটেও থাকবে, বাট দ্য টলারেন্স অফ হাই ফ্যাট, এটা একটা কোয়েশনেবল ম্যাটার, অ্যান্ড দ্য ক্যালোরি অলসো। থ্যাংক ইউ।
So I think we have a wonderful session, and thanks to both of them. Shrupratik escaped from any question, but thank you once again, the entire audience, for giving your patience hearing, and I think we have learned a lot of things. I mean, this is very important sessions. Thank you. So can I conclude this session? Hello. Yeah. Now we are going to have the second session of this evening, and I'll request, as chairperson, Dr. Dibyendu Bhattacharya, who doesn't need any introduction. He is going to chair this session. Sir, please try to maintain timing. This is very important. I know the subject that Nilanjan is going to say is something very close to his heart, so he might take a little bit of more time, but this should not be followed by everyone else. And questions should be made very specific, one-liner, as I already said, so that we have enough time at the end of the day. So over to you, sir.
Thank you, Nirmala. Thank you, EKDG Organizing Committee, for giving me the opportunity to chair two very important sessions by two very legendary endocrinologists of our country, one by one. and very important topic. First topic is circadian rhythm and how this rhythm actually affects the human body in the short term and in the long run. And the master speaker is Dr. Nilanjan Sengupta. He does not need any introduction. I think he will delve into the deeper insights and the clinical implications of the subject. Start, Nilanjan. Welcome.
Thank you, sir. Thanks, EKDG and Dr. Shomit and Dr. Vinayak in particular for making me a part and giving me a topic, as Nirmala has pointed out, close to my heart. Exercise, sleep, stress, and circadian rhythm. Now, we all know, as defined by WHO, health is a state of complete physical and mental well-being and not merely the absence of disease or infirmity. So now we have to go beyond disease, we have to go beyond pharmacotherapy, and we have to think of lifestyle. And this is a busy slide, shows the interaction between heart health, metabolic health, mental health, and cancer. And you see in the central to it, you have inflammation, HPA axis asynchrony, then peripheral clock, and many other things, leptin, ghrelin, so, and many neurohumoral mechanisms. Let's start with exercise. Of course, Supratik has alluded to that. Exercise actually has very many beneficial effects on the body, increases aerobic capacity, improves insulin sensitivity, this we all know, improves glucose control, increases oxidative capacity, renders the lipids less atherogenic. That translates into control of type 2 diabetes, control of MASLD, control of PCOS, and overall decrease in morbidity and mortality. Now, exercise leads to elaboration of very many exerkines like irisin, apelin, mucilin, myonectin, decorin, and interleukin-6. And they have very many beneficial effects. So the beneficial effects of exercise at the molecular level are actually mediated by these myokines or adipokines, together called exerkines. And this slide actually shows the acute adaptations to exercise. There is increase in glucagon, decrease in insulin, increase in cardiac output, there's vasodilatation, and there is lipolysis or triglyceride mobilization of the fatty tissue. And also there are changes in the muscular physiology leading to increase in glucose uptake of the muscle, increased glycolysis, fat oxidations, and so on. Similarly, there are chronic adaptations to the exercise, have beneficial effects on beta cell function, have beneficial effects on cardiac contractility and VO2 max, vasodilatation, and peripheral resistance, translating into improvement in hypertension, muscle mass, as has been talked about sarcopenia, so improves muscle function, muscle strength, and also the adipose tissue. At the whole body level, this increases the aerobic capacity, insulin sensitivity, glucose control, oxidative capacity, and also, decreases the oxidative stress. So these are the cytokines and the myokines that are elaborated upon exercise, and they exert their effects. Now we come to stress. What is stress? Stress can be defined as a real or perceived threat to homeostasis or well-being, and it can be either psychological or physical or both. So we all understand what is emotional stress, but surgical stress is also a physical stress. A stress of illness is a physical stress. Stress of infection is a physical stress. And what does stress do? Again, as Supratik has pointed out, it actually activates the sympathoadrenal system, the renin-angiotensin-aldosterone system, as also the hypothalamo-pituitary adrenal axis. So stress leads to release of catecholamines, which results in mobilization of stored energy, causes tachycardia, increases cardiac contractility, and there is redistribution of blood flow. Again, there is activation of the hypothalamo-pituitary adrenal axis, ultimately translating into increased glucocorticoids, and the tissues are exposed to increased glucocorticoids, and there are wide-ranging metabolic effects of that. So chronic stress leads to epigenetic changes, leads to vascular remodeling, and thus can lead to atherosclerotic cardiovascular disease and add to hypertension, can affect beta cell function, can affect insulin sensitivity at the target organs, thereby offsetting glycemic control or thereby precipitating diabetes. And there are changes in the body fat too. So chronic exposure to stress not only leads to these metabolic changes, but also makes the animal more prone to develop addictions, increased intake of palatable food, altered innate immunity leading to infections, altered gut microbiota, again leading to metabolic and other complications, and ultimately that translates into cardiometabolic disease, which we are discussing about, but that also may predispose more to cancer, more to infections, and so on and so forth. And this stress not only operates in adult life, this stress can start in the fetal life, and we all know about Barker's hypothesis. If there is IUGR, so IUGR is a stress. If the fetus is stressed, there are epigenetic changes, and in later life, these children are more prone to develop cardiometabolic disorders. Again, this stress not only operates in the intrauterine life, can operate in early childhood, through adulthood and senescence, ultimately leading to a state of chronic low-grade inflammation, HPA axis stimulation, stimulation of the sympathoadrenal system, stimulation of the tissue RAS, ultimately leading to metabolic disease, translating into increased mortality and morbidity. At the last part of my talk, I come to sleep and circadian rhythm. Only yesterday we had the Sleep Day, National Sleep Day, or international, I'm not sure. So sleep is very important. There are certain glossary of terms. Time precludes even going into this, but suffice it to know, I will be using a German word, Zeitgeber, which actually means timekeeper. We have an internal Zeitgebers and the external Zeitgebers. Now, chronotypes. This is a very interesting thing. Some of us are owls, some of us are larks. So, while we know that the chronotypes is essentially a learned behavior, studies have shown that this also has a genetic basis. And the late chronotype may be higher in males. And as with the children, early chronotypes are common because children go to bed early and wake up early. But as we grow up, many of us change into the late chronotypes. So what are the sleep abnormalities we know of that can be categorized into three groups? Impaired sleep, that is insufficient sleep, fragmented sleep, or poor sleep quality. Then, of course, defined sleep disorders, disorders of sleep like obstructive sleep apnea or insomnia syndromes, and the circadian misalignments like the evening chronotype, the social jet lag, and the shift workers. So as again Supratik has pointed out, there is a U-shaped relationship between sleep and cardiometabolic diseases. So the optimal duration of sleep should be 6 to 8 hours or 7 to 9 hours. If you sleep less than that, you are at a greater risk of developing cardiometabolic diseases. If you sleep more than that, even if you do not, even if you are at not a greater risk of cardiometabolic diseases, that reflects some abnormality in your cardiometabolic health. So social jet lag, now this is very common these days. Many of us actually work, have a particular schedule from Monday to Friday. We work and then go to sleep early, and maybe on weekends we remain awake till say 2 or 3 in the morning, go to sleep early in the morning, and wake up next day very late in the morning. So this is social jet lag, and studies have shown that social jet lag has deleterious effects on metabolic syndrome. Those who follow that, and a social jet lag of more than equal to 2 hours was associated with risk of the components of the metabolic syndrome. And how does it act? Actually, waking leads to decrease in the leptin levels and increased levels of ghrelin. And that actually also alters appetite and feeding. So this is, again, the internal Zeitgeber is mainly located at the suprachiasmatic nucleus, and the external Zeitgebers are mainly the light-day cycle, the entrainment. Now, what is happening in the industrialized countries? We are being less exposed to light in the daytime when we should be, and we are more exposed to light at a time, at a period of day when we should not be exposed to. So there is a mismatch between the biological clock at the suprachiasmatic nucleus and the social clock. And like decrease in stage 3 non-REM sleep will lead to decrease in GHRH and GH pulses, and this leads to affects fat burning, bone building, and tissue repair. And sleep insufficiency also increases sympathetic, that also is a chronic stress that leads to sympathetic activity and elaboration of pro-inflammatory cytokines. So this is the actually misentrainment between the internal Zeitgeber and the external Zeitgeber, and that if the clock gets broken, then all problems come. So sleep deprivation or sleep restriction or experimental sleep deprivation increases energy intake and has its obesogenic effects. Food consumption is increased to compensate for the additional energy costs of wakefulness. There is increased appeal and consumption of desserts by the adolescents, those who remain awake. It also influences the satiety hormones, leptin and ghrelin. Increased ghrelin notably leads to increase in food intake. There are hippocampal changes leading to memory impairment, and amnesiacs eat multiple meals consecutively. It reduces the resting metabolic rate and primarily modifies lipids, neurotransmitters, gut metabolites, and affect oxidative stress, ultimately translating into increased cardiovascular disease risk. And this is regulated by a lot of genes like the serotonin, the clock BMAL1 are the more important genes. I won't go into the details. These are the core circadian rhythm genes, of which clock and BMAL1 are the most important. And these are the peripheral circadian regulated genes. And if the balance is tilted in favor of the peripheral clock genes, which are largely detrimental, and the central clock genes will try to maintain the internal homeostasis, then all the problems, especially the metabolic and psychic problems, would come. So this is the internal rhythm, that is the internal Zeitgeber. The external Zeitgebers are mainly the light. This is the light day entrainment. And the third component to it is the social rhythm, which has been imposed upon us by the price of civilization that we are paying. So this is an interesting snippet. British Columbia has done away with the DST from 8th of March this year, or they are in a permanent DST mode. So the American Diabetes Association also understands the importance of sleep. So in the holistic management of diabetes now, the sleep features very importantly the chronotype, the sleep quality, and the sleep quantity. And this slide also shows the same. And therefore, this is my last slide. This is the circle of evil. At the top of it is circadian misalignment, leads to poor sleep. Poor sleep leads to stress. Again, stress leads to poor sleep. This is a bidirectional relationship. Stress leads to physical inactivity. So also physical inactivity leads to stress. So again, a bidirectional relationship, ultimately leading to cardiometabolic diseases. And this becomes a self-perpetuating cycle. So therefore, realistically speaking, for metabolic health, as Dr. Supratik Bhattacharya was pointing to, for a good metabolic health, we need adequate sleep. We should be should be larks rather than owls. We should take regular exercise and physical activity. We should also think of mental well-being. Sleep and mental well-being are not synonymous. Apart from being sleep, you should also think of mental well-being. That only will lead to holistic metabolic health. Yes, of course, I do not downplay the importance of pharmacotherapy. That is also very important. But in addition to pharmacotherapy, all these non-pharmacotherapeutic approaches are also very important, and at times they are neglected, but time has come to emphasize them in a great way. Thank you.
Thank you, Dr. Nilanjan, for completing the huge and complex subject in 19 minutes time. Please come in the chair. So our next subject is also very interesting by academician and a very legendary endocrinologist, Dr. Soumik Goswami. He is present here, and he will talk us on the subject of the BMI concept already has gone, and what is the new concept, and the GLP-1 use in obesity, and many more, as you see in the brief, the classification in the brochure. So please, Soumik, you start your presentation.
So very good evening to all of you. Sir William Osler, I begin with one of his quotes. He said that the desire to take medicine is perhaps the greatest feature which distinguishes man from animals. And animals do not have obesity. Mind it, animals in the wild, those not in proximity to humans, rarely have obesity. Unfortunately, we are not animals. We are in an evolutionary mismatch. We have obesity, and desire or not, we do need to take medicines at times also for obesity. The reason why we have obesity is again multifactorial. Hereditary is a big contribution. Social determinants of health is also a big contribution. So you can blame it on your parents or on the politicians ruling you. At the same time, there are biological factors, there are environmental factors, there are certain medications which could lead to obesity, but all said and done, to look at it in a very simplistic yet complex way, you can say that it's a state of increased adiposity which might have certain health consequences. But the problem is that we are not always measuring body fat. We are looking at overall body weight or other parameters and trying to get an idea of the amount of body fat that is present. Again, it's not a benign disease. It's associated with more than 200 health conditions, which could be metabolic, which could be mechanical, which could be neuropsychiatric, and of course more than 10 cancers or a dozen different cancers could also be a complication which is a consequence of obesity. It is also known that if you lose body weight, you get certain benefits, and the amount of weight loss relates to the benefits that you get. With 5% weight loss, you get certain metabolic benefits. With greater amount of weight loss, you also get some mechanical benefits. And it's only when that you lose 15% of more of your body weight that you actually get some mortality benefit. Is there an upper limit of threshold, or is there an upper limit of benefit? If you look at the bariatric surgery trials, 20% or more weight loss is the highest limit beyond which possibly there's no further health benefit of losing body weight. Again, we need to keep in mind that we are talking of losing body weight, not body fat. We consider losing body weight to be a surrogate of losing a certain amount of body fat. The exact amount is not known, which in turn translates into these health benefits. Now, how do we lose body fat or body weight as a surrogate? The foundation, of course, is good lifestyle modification, a healthy hypocaloric diet. Both these adjectives are important. Aerobic and resistance training, and the third pillar of lifestyle modification is behavior therapy and counseling, which often is lacking when we resort to good lifestyle modification. The problem with lifestyle is, one, it has modest effects, around 5% if you look at the mean effect, 10% if you can really push the envelope, but it's usually around 3 to 5%. The other problem with lifestyle is that when you are dealing with obesity, it's a chronic relapsing disease. It starts getting back to you. The moment you go beyond that phase of intensive lifestyle modification, the weight starts coming back. About half of the lost weight comes back in 2 years, and if you go to 5 years after intensive lifestyle modification, you regain about 80% of your lost weight. And the reason why lifestyle alone might not be sufficient is again our evolutionary adiposity set point. The body always tries to maintain adiposity at the highest level that it sort of gets to maintain during the course of your lifetime. Whenever you lose weight, the body interprets it as starvation. And whenever there is starvation, certain compensatory mechanisms come into play, because over millions of years, starvation was much, much more dangerous than overnutrition. There was more often starvation than overnutrition. So your appetite increases, your metabolic expenditure, your resting energy expenditure comes down, which sort of tries to push back your body weight, or rather your body fat, to that adiposity set point, that maximum adiposity set point which you had attained earlier. And the central hub where it all happens is the hypothalamus. The hypothalamus is the central hub which increases your appetite once you lose body weight, and plays a role in reducing your resting metabolic expenditure when you lose body weight. So if you lose body weight with lifestyle and prevent your adiposity set point from causing you to regain your lost weight or your lost body fat, you need to target the hypothalamus. You need to target your appetite. And of course, if you look at the anti-obesity pharmacotherapy, with the exception of orlistat, all the other drugs which are actually beneficial, because if you look at orlistat, the mean weight loss in long-term trials is only 5%. If you look at the drugs which actually target appetite, and of course the two jewels in the crown, anti-obesity dose of semaglutide 2.4 milligram and tirzepatide, maximum tolerated dose, you usually lose about 15% or 22% of your body weight, depending on whether you are on semaglutide or tirzepatide. However, we need to keep in mind that this degree of weight loss is in patients with obesity without diabetes. If you look at diabetes and obesity, you usually lose about 40% less compared to this 15% and 22% weight loss mark. Now, how much weight do you need to lose? As I said earlier, you have different degrees of weight loss for different degrees of benefit. So there could be someone with obesity who just has impaired glucose tolerance or early dyslipidemia, who could very well do with that 5% weight loss that lifestyle modification gives you. However, if you fail to maintain your body weight loss after lifestyle modification, pharmacotherapy helps to reduce your appetite and helps you to keep your body weight at a lower level. At the same time, if you want greater degrees of weight loss, not as high as bariatric surgery, but in the range of 10, 15 or 20%, you have pharmacotherapy to bridge the gap between lifestyle modification, which as we saw is not sustained over the long term, and the huge weight loss that metabolic surgery gives you. Now, coming to the issue of how to measure body weight or how to measure obesity, as our chairperson was telling us, there's a huge problem with BMI. Now, if you look at BMI was never intended to measure obesity. It was sort of discovered or invented by a Belgian astronomer, Adolphe Quetelet, who was interested in finding the ideal average man. He was looking at averages of humans and found that BMI gave you a sort of a nice ratio. In the 1960s, 70s, nutritionist Ansel Keys, he looked at several parameters, measuring only the weight and the height, looking at only the weight and the height, weight by height square, weight by height cube, and so on and so forth. And he found that if you measured body fat with the calipers, and if you looked at BMI, they had a good correlation. He said that it's a good epidemiological tool, but at the individual level, it is not a good marker of obesity. But the society is latched on into it, and we know that today BMI is almost a surrogate for obesity, although it's not at all a good tool at the individual level. In India, the problem is further compounded because we know that for the same BMI compared to someone of European or Caucasian descent, we have more than twice or 2.5 times as much body fat, and it's mainly concentrated in the viscera. It's not gluteofemoral adiposity or subcutaneous fat, but mainly visceral adiposity, which makes up a greater part of our body weight at the same body mass index. So in Indians, when you look at body mass index, you are actually doing a disservice. You are not picking up obesity. High BMI, you are likely to be obese, but normal BMI, more often than not in the Indian context, you are still likely to be obese or overweight. You are underdiagnosing obesity if you're looking at BMI alone. And even if you look at global data, you see that if you have what you call metabolic unhealthy normal weight, you have a greater risk of cardiovascular disease compared to if you have metabolically healthy obesity, which sort of shows us that if you look at BMI, BMI is a very inaccurate marker of looking at cardiovascular risk as well. So the only guideline sort of which has done away with BMI as one of the essential criteria is the Lancet Commission. So it has turned out to be one of my favorites as well, where you can directly measure the body fat. For Indians, again, there is controversy, but as of now, more than 25% body fat for males and more than 30% body fat for females can be considered to be obese. You can look at any two anthropometric criteria, which can be waist circumference, waist hip ratio, or waist height ratio. Any two of them above normal, you are obese without BMI, or you have a third criteria where BMI with one anthropometric criteria qualifies for obesity. But again, there are at least two criteria here which are independent of BMI. And it looks at a risk-based approach. It classifies obesity into preclinical obesity and clinical obesity. So if you have obesity, but you are metabolically healthy, you do not have any functional limitation, you have preclinical obesity, where prevention, good lifestyle is the key. On the other hand, if you have any of these several organ dysfunctions or any functional limitation, you have clinical obesity, where you should have a low threshold for pharmacotherapy, or you should almost always be a candidate for pharmacotherapy. But there's a big problem. The problem is that the guidelines still look at a BMI-based approach. If you look at the label of the drugs that you are using, 27 or more with comorbidity, 30 or more without comorbidity, the Endocrine Society of India has lowered the cutoffs to a certain extent, but again they are based on BMI, which are inaccurate, at least in our population. However, we need to keep in mind that you should go for pharmacotherapy only if you are not meeting your goal with lifestyle intervention. So you should lose at least 5% of your body weight over 3 to 6 months. That is when you can say that lifestyle intervention is working, although as we saw, for most of the health benefits, you need 10-15% weight loss. The guidelines say that you can consider a lower BMI cutoff in those who are unable to exercise, so that they are then able to exercise, but doesn't specify how low is the BMI. Again, it's based on BMI and not beyond BMI. So if you look at the drugs that are available in our country to treat obesity, the two best drugs, as we said, are tirzepatide in terms of absolute weight loss, followed by semaglutide, 2.4 milligram. They are more or less closely matched, except for the fact that tirzepatide shows greater weight loss. Tirzepatide has dedicated data in OSA. Semaglutide has dedicated data in patients with osteoarthritis. In patients with MASH, you have a phase 3 trial as well as a label indication. And in CKD with lower doses of semaglutide, you have a dedicated trial, which we are still lacking with tirzepatide. If you look at the pharmacotherapy, again, how long? Possibly lifelong. The quicker you lose weight when you stop therapy, the quicker you gain back weight. So with semaglutide and tirzepatide, after discontinuation, you regain the lost weight in about 1.5 years. If you compare it with lifestyle modification, possibly you regain it much more slowly. If you look at, again, pharmacotherapy, GLP-1 or GIP-based pharmacotherapy, these are the contraindications. Gallstone is a relative contraindication. Moderate to severe NPDR, you need to be cautious with semaglutide. They actually improve depression and quality of life, but in those with severe depression, they can cause anhedonia, and in some there could be suicidal tendencies. You need to be careful. Lack of high protein in diet seems to be a bit counterintuitive. You are taking an expensive drug but not taking protein in your diet, but that does happen in our country. And in elderly women, there's a risk of worsening of osteoporosis, particularly if you reduce the lean body mass. This was a paper which was published just a couple of days back, which looks at the risk of ischemic optic neuropathy, which we know is something of a concern, although rare, with these agents, and it shows that the risk is highest with 2.4 milligrams of injectable semaglutide, followed by 1 milligram of injectable semaglutide. Interestingly, oral semaglutide or injectable tirzepatide do not carry an increased risk of ION, is what this study suggests. So finally, is lifestyle modification at all necessary with pharmacotherapy? And this is actually a question which needs to be answered. This is so because if you look at the step trials with semaglutide, the degree of weight lost was similar with less intensive lifestyle modification and more intensive lifestyle modification. And this more intensive lifestyle modification included behavioral therapy and a low-calorie diet, at least in the initial part of therapy. But the degree of weight loss was not much different. If you look at the SURMOUNT-1 trial, the degree of weight loss was around 20%. If you look at the SURMOUNT-3 trial, the degree of weight loss was actually higher. So the difference was because, unlike step 1, step 3, and SURMOUNT-1, in SURMOUNT-3, there was an initial phase of intensive lifestyle modification followed by pharmacotherapy. Whereas in the other trials, lifestyle modification and pharmacotherapy were started concurrently. Similarly, with liraglutide 3 milligram, when you followed it high doses of liraglutide after intensive lifestyle modification, you had additional weight loss. So in short, the message is that if you begin intensive lifestyle modification with pharmacotherapy, possibly there's not much additional benefit. On the other hand, if you do sequential lifestyle modification followed by pharmacotherapy, you might have additional benefit. So this is my last slide, which tells us that very soon we are going to face a storm of inexpensive sort of anti-obesity medications. We need to be careful because although the jury is out on lifestyle modification, at least sequential lifestyle modification followed by therapy is important, particularly high quality protein resistance training to maintain lean body mass. We need to spend that extra minute with the patient with severe comorbidities rather than with the patient who doesn't have a comorbidity but is interested in anti-obesity therapy for cosmetic reasons. And most importantly, we need to tell our patients that this is a lifelong therapy, possibly a lifelong therapy, and there could be some initial gastrointestinal problems. So just like in any other part of metabolic medicine, one size does not fit all. It's the same for obesity pharmacotherapy. But as we said initially, humans are not animals, and unfortunately more often than not, we will need obesity pharmacotherapy. Thank you.
Thank you, Shobhik. Please come in the chair. Please come here, Shobhik. So I was just feeling that I was hearing lectures, two lectures in the lecture theatre of a medical college. So any question from the two speakers from the audience?
ওইটাই ভুলে যাই তো ঘুমের কথা অ্যাকচুয়ালি পাখির সঙ্গে ঘুমাবো পাখির সঙ্গে উঠবো স্লিপটা তাই পাখির সঙ্গে ঘুমাবো পাখির সঙ্গে উঠবো ওইটা ইয়েতে ওইটা প্যাঁচাটাকে আপনি কেটে দিয়েছিলেন প্যাঁচাটাকে
পাখি
হ্যাঁ অ্যাকচুয়ালি যেটা আমি পিজিতে থাকলে একটা পেপার করেছি তাই দেখছি যে লেট নাইট যারা খাচ্ছে ডিনার করছে লেট নাইট তাদের মেটাবলিক ডিসঅর্ডার হচ্ছে বেশি ফ্যাক্ট এটা
That's right. Yeah.
So to Shomik, I mean, this is just a small understanding. We know obesity is related to depression in many a case. I've seen a lot of patients who are obese, particularly females, and have a lot of depressions associated. Now, the drugs that we are having can cause depression as well. As you said, I mean,
that's very rare actually.
That's rare, but
because we have had a trial called the history trial and other trials which have looked at depression and schizophrenia. Overall, they have found an improvement in quality of life, rather a decrease in depression. However, there could be exceptions. In some patients with severe depression, food is sort of a comfort for them. So if they develop anhedonia and if they develop a distaste for food, that might worsen depression. But that's an exception, not the rule. But you need to be careful in individuals with severe depression. There are rare reports of suicidal tendency. It's not the norm.
But my issue is, I mean, I have seen quite a number of patients who are on antidepressive drugs, right? Now, when I think of adding this semaglutide or tirzepatide, do I have to give them any other, I mean, the caregivers, any other advice?
Not usually. In those with stable depression who are doing well on antidepressants, you'll actually improve their outcomes, improve quality of life, and reduction in depression has been seen on those scales, usually.
So no need to change the antidepressants.
But in those with severe depression, not well controlled on antidepressants, you can still give, but you need to be careful and need to ask them at every visit how they are doing.
Thank you.
Sir, I have two questions for two speakers. First to Dr. Nilanjan Sengupta. Sir, is there any difference in the beneficial effect of sleep with a natural sleep and that of a drug-induced sleep who takes sedatives regularly? And the second question to Dr. Somik is, when you advise for a weight loss, 10 to 15%, do you tell them the time by which they should try to achieve that? Well, regarding sleep, I think natural sleep, everything what is natural is the best. There are studies that sleep, whether it's naturally induced or whether it is induced by sedative hypnotics, it is the sleep duration and sleep quality that are more important, but natural sleep is always desirable. If that can be done, again, pharmacotherapy should come after, the non-pharmacotherapeutic options are exhausted, or as Shomik has pointed out, it's not or, maybe at times it adds non-pharmacotherapy along with, if needed, pharmacotherapy.
Say that if you lose at least 5% of your body weight over 3 months or 6 months, you can be a bit more patient. Pharmacotherapy or lifestyle, whatever is working. That 10 to 15% weight loss is usually after a year or more of therapy. You usually need about 60 weeks of therapy for them, or more than a year of pharmacotherapy to reach the peak effect. And we are looking at a lifetime of benefit, not short-term benefit. So you can wait for a year or more to reach that 10 to 15% mark.
So thank you. I conclude the session, and thank you both the speakers.
So thank you, sir. Thank you both the speakers for wonderfully taking us through a very, very important subject. Now, the time when Shomik will be invited to talk on a very important subject, which I don't think is spoken to in many CMEs or conferences, which is determinant of GLP-1 receptor agonist-based therapy for non-responders. I mean, we know there can be super responders, there can be non-responders, but how we can determine them or how we can go about in understanding the pathobiology or pathophysiology of non-responders. So over to Shumit.
Thank you, Nirmala. So we will have we already have two weight reducing molecules. We have semaglutide and we also have dual agonist tirzepatide. We are going to have many more. We're going to have cardiovascular and all other drugs. The issue is, do we use them as a trial and error method? একটা দিলাম কাজ করলো না 3 মাস পর, then we give the other one, or do we have some clinical determinants by which we choose specifically responders and non-responders? Now, if you look at the step trial, all the step trials which were done with semaglutide, you find that more than 20% weight loss happened in around 30, 39 or 40% patients. But we have a significant, near about 16, 17% of people who did not even reach the 5% of weight loss. Now, imagine putting someone on obviously, as Shomik said, we'll have all those things quite cheap. But as of now, as we stand today, giving someone a 10,000, 12,000 rupees therapy a month, wait for 3 months and say you're a non-responder after exhausting 30,000 rupees. So it wouldn't have been better if we can identify the non-responders in advance. Now, first we need to understand every single drug that we use, oral drugs or even injectables like insulin, has two predominant areas we need to look into. One is PK/PD. PK means, suppose you're injecting an insulin, so how is it absorbed under the skin to the systemic circulation? And PD means, how is the drug sitting on the receptor and causing the effect? But GLP-1 has another level. So this is the only thing we need to remember, has a 3-level structure. One is the PK, how is the absorption happening after subcutaneous injection. 2 PD. And third, even after the signal is generated from the receptor, there is the central controller in the brain. So it has to go and act on the satiety center. Only then you're getting the benefits. So this is one very important thing we need to remember. Now remember, in obesity, you already have a hyperexpression of collagen 1,3. So the subcutaneous space can be fibrotic. So when we are injecting, the absorption of the drug can be erratic. Now absorption doesn't only happen from subcutaneous space, it has to go through lymphatics and through lymphatics into the systemic circulation. Hyaluronan does what? It increases viscosity, slows down the absorption rate. So you can expect certain degree of pharmacokinetic interference in the subcutaneous space in obese patients. Now look at what happens in type 2 diabetes. There is overexpression of DPP-4, which breaks down GLP-1 molecule. Also, the semaglutide molecule at the 26th position of lysine has a fatty acid which is attached, which binds with albumin and increases its half-life to 7 days. Now, if you in diabetic patients have glycation of the albumin, that might reduce the binding sites of the semaglutide and blunt its action. So these are theoretical concerns from the subcutaneous space. Now, pharmacokinetics does not only mean interfere in subcutaneous space. You're giving the molecule, patient is not taking it. Or sometimes you're microdosing, where the drug concentration is actually not reaching what it should reach in order to save cost. Instead of 7 days, some of the patients has been prolonged to 10 days, 12 days. It looks good from a cost perspective, but you're actually not reaching the concentration required for efficacy. Cmax is not achieved, so the efficacy will be blunted. This is not that important once you get through the pharmacokinetic barrier. PD are very rare, polymorphism of the structures or the receptors which can happen. Now, this is not responsible for non-responders. In very rare individuals, there might be some blunting of response. If you have those specific polymorphism, now is not the time to discuss this, because once we have polygenic risk scores coming in, where small SNPs can be identified and they can be joined together to tell you whether someone is responder or non-responder. We have not reached that state as of now. Most important is the brain. We need to understand there are 2 important regions in the brain. One region where the GLP-1 is acting on the switch of satiety. It is turning on the satiety switch, and so with little bit of food you feel full. But there are some patients you must have noticed who are taking your GLP-1 and telling you, these are the ones where the mesolimbic system is hyperactive. The reward system, where the dopamine is very high. And the body is saying, the more you eat, the more happy I will make you. So here, the GLP-1 might not be effective. Now, hypothalamus, if individuals who have high inflammatory cytokines, it is very commonly seen in type 2 diabetic patients. Simple tests like HSCRP or a ferritin, if it is elevated, is indirect signs of gliosis in the hypothalamus. So again, your satiety switch might be locked. What you want to do with GLP-1, it doesn't happen. So this is the healthy part you see. In the healthy part of the tissue, you have suppression of neuropeptide Y, POMC is activated. But if the switch is clogged due to fibrosis, you find that you won't get the desired response. Even after PK is fine and the receptor signal has gone, but something is happening at the level of the brain. The reward center is extremely important, because remember, at the end, this will help us to choose between a GLP-1 and a GLP-1 GIP combination. Now, the therapeutic amplifier is type 2 diabetic patients. So you might have an obese patient whom you're giving a semaglutide or a tirzepatide. You might have a type 2 diabetic patient who's obese and whom you're giving a GLP-1 or tirzepatide. What we see is there's a blunting of response in type 2 diabetic patients. The amount of weight loss that you get in non-diabetic is not the same. This is a paper in the Obesity, which is the Journal of USA, the official society in USA. We published this data based on all the trials that has been done with tirzepatide, with semaglutide, with survodutide and everything, and retatrutide. And you can see the gap between the weight loss blunting effect is significant in case of a GLP-1 or dual agonist, but not so in triple agonist, because triple agonists are burning your fat so much more that the blunting of effect is nullified. But with whatever we are doing today, the expectation should be, if your type 2 diabetic thinks that that patient is going to lose a weight like a non-diabetic, is not going to happen. Now, these are theoretical, subcutaneous space and hyaluronans, and what are the clinical pointers? Now, these are the red flags. A BMR can be easily assessed using an app called the Harris-Benedict equation. It's a very simple thing. Someone having a low BMR, even after eating less, will accumulate a lot of fat. So you have a phenotype where a patient comes and tells you, "Doctor, আমি তো কম খাচ্ছি, কিন্তু মোটা হয়ে যাচ্ছি." This is the metabolic phenotype. And the other one is the appetite phenotype, who says, "I'm just eating and eating and eating and gaining weight, do something about it." These are the two predominant phenotypes. Now, before putting someone on therapy, clinically assess, especially a type 2 diabetic patient on insulin, please palpate the abdomen, the subcutaneous space, because that's exactly where we're going to inject the GLP-1 or GIP. And if that space has a lot of lipohypertrophy, dystrophy, and has fibrosis you can feel, you need to be very careful. Probably if you're injecting in that same place, whether it is insulin or GLP-1, there'll be blunting of effect, you won't get the response. People coming with bunch of tests, nowadays they all come with 40, 50, 60 parameters. Look at HSCRP, look at ferritin. If they're abnormally high, you can expect certain interference at the central level, especially they could be hypothalamic gliosis. So how do we overcome that? This is the phenotype that I am proposing. I have also designed a study on this, which people who are interested, we can discuss later on. I am proposing that there are two distinct phenotypes. One, people who come with hunger and wants to kill their hunger and hence their weight. Second, they are actually the metabolic phenotype who are gaining weight in spite of eating less. And there could be overlapping, phenotypes in between. The hunger-free predominant phenotype is something which has two aspects to it. One, the baseline hunger scores, if you do, is very high, and they have a dysregulation in the reward pathway. This is extremely important. They will respond to GLP-1 therapy, but if they are not responding to GLP-1 therapy and still eating more, what is the ideal companion to it? A GLP-1, a glucagon agonist, or an amylin? I'll show you later on in the last slide. The metabolic predominant one will কম খাচ্ছি, মোটা হচ্ছি, has associated features. Has extreme visceral adiposity, has an MSLD, have all those features, has OSA. These are the ones who need more energy burning. Here, just switching off the satiety center won't work. We need them to burn more energy. Now, this is a diagnostic dashboard I'm proposing. There is no such clinical thing. I'm proposing this is something we can work on. If your HSCRP is more than 3, extreme insulin resistant, which is defined as triglyceride to HDL ratio of more than 3 to 4, if you have the waist height ratio more than 0.6, low baseline hunger, evidence of MSLD, OSA, you're probably dealing with the metabolic type. Probably the type you have to bring on board a GLP with GIP. Simple GLP-1 probably won't work. So strategy 1, if I need to burn more energy, I need something which is going to overcome my insulin resistance or burn the excess fat that I have. Excellent in overcoming insulin resistance is GIP. So someone having acanthosis nigricans, extreme adiposity, having skin tags and everything, if there is increased insulin resistance, probably a tirzepatide will be a better option to start off than a simple semaglutide. Now I need to burn more energy. আমি কম খাচ্ছি, মোটা হচ্ছি, I don't have insulin resistance. Now this is where energy burner comes in. Glucagon agonist is the ideal partner because it burns your fat. And I am hungry, I am eating more and I'm fat. I'm taking GLP-1 in adequate dose, but I'm still hungry. I have to shut down the mesolimbic system. This is where amylin comes in. Because amylin exactly works on the reward center. So when we're going to get CagriSema, these are the phenotypes who are on GLP-1 and still hungry. So these are not ideal candidates for GIP or glucagon agonists. You need to put the amylin out here. So this is my last slide, a decision algorithm chart we can think of. As Shomik mentioned, whether you give them lifestyle or any drug, 3 months is the point you assess. At least 5% of weight loss should happen to say it is successful or not. Ask a simple question. Are you feeling hungry? Do these patients have their inflammatory markers high? Do they have extreme evidence of insulin resistance, or do they have associated factors like MSLD, OSA? If yes, it's a metabolic phenotype. Probably I will choose a tirzepatide here. Someone saying I'm very hungry, I'm and I'm feeling fat, I'm gaining weight, I will start with the GLP-1. Once amylin comes in, these patients probably will be a candidate for CagriSema with amylin. And at the other end, if GIP-1 doesn't work along with GLP, we need to burn more fat, then we need to put them on retatrutide, which is the triple agonist. So this is a sort of a algorithm that we can create out of it. So it's time probably, the next 2 to 3 years, we are probably going to see more phenotype searching. not trial and error of putting one drug and then putting the next. We probably find out with our experience certain phenotypes which we can choose and then make an informed choice of which drug to give to which patients. This is just a hypothesis I showed you. These are all based on good mechanistic data of MRI-based, functional MRI-based scans, but not clinically endorsed as of now. Thank you very much.
Please. Questions from the floor? So, yes? So, if there are no questions, so we would be having, this is a basic practical question, 2 types of semaglutide, I mean the pharmacosimilar semaglutides, the oral semaglutide as well as the injectable ones. So how do you categorize the patients who would be choosing an oral semaglutide vis-a-vis injectable semaglutide?
I think from the phenotype point of view, I think both will be falling in the same category. But patients who are not willing for injections, I think that's where the oral comes in. I can't tell you the answer after the price being slashed, how patients are going to look at the lower cost GLP-1 once weekly therapy vis-a-vis the high cost oral. But one thing is for certain, once orforglipron comes, because that is a chemical structure, it is not a tertiary protein structure, so it will be very easy to manufacture that. Probably you will see a slash in cost much, much more with that particular product. And then I think the real game will come from the cost perspective, how the oral semaglutide is going to respond to that.
Even for glycemic control, how do you compare the data you have with oral semaglutide vis-a-vis injectable semaglutide? I'm not talking about obesity, the higher dose, but for glycemic control.
Again, Nilanjan, is very difficult because the baseline that both of them used were not very homogeneous. So it's very difficult to say how is. But I think the oral has tried to bulldoze the bioavailability by increasing the dose in an astronomical level. I do not know. My clinical experience says I've seen lots more GI side effects with the oral than with the injectables rather. And rather the dose titration I found much easier with injectable than oral because of the side. I've rarely been able to reach a 14 milligrams. I've always have to scale down to 7 in majority of my patients. So from the data point of view, I think oral has very good data with CVOT in SOUL trial. So if someone tells me that I want to be on oral therapy, I have absolutely no qualms in putting them on oral semaglutide. Injectable, again, see, if the patient has a cardiovascular problem and has an MASLD, I might be tilted a little bit towards the injectable one.
Yeah, but I think injectable semaglutide is convenient and predictable than oral semaglutide, whatever the patients may think otherwise. So thank you very much for your very illuminating and thought-provoking talk. I think we would be discussing his dashboard maybe after 3 years when that may come into the treatment paradigm. So thank you, Shamit, once again.
So we'll have the panel now. Shomik can join us. Binagda, can you take us through? So these are stimulating questions, but if you want to budge in, the mics are there, you can come and ask questions. Right, Binagda, I think? Yeah.
Okay. Hello, am I audible? Yeah. So essentially what happened was just about a week back, Shomik told me that you should do a panel discussion and it should be case-based. And now do I search for cases that I keep, over the months, years and things like that? So I decided that I will take up cases that I have seen last week in one index clinic. And there are 3 patients and I have nothing more to say than just this. So type 2 diabetes, dyslipidemia, subclinical hypothyroidism, presents with mouth ulcers, weight loss, weakness and genital irritation, is on thyroxine 25, atorvastatin, glimepiride, linagliptin, 40 kilograms, 1.5 meters, very underweight, pulse 90, blood pressure 110/70. I do not usually examine abdomens as a matter of routine. I examined this patient's abdomen and had a large liver. And indeed there is hepatomegaly with fatty liver grade 3, no splenomegaly, no other abnormal signs, HbA1c 12.1%, fasting 298, creatinine 0.9, TSH1, no transaminitis, hemoglobin of 6, MCV of 59, platelet count 161. Now, if you want, I can give you more information. I have intentionally chosen to give you this much of information. The patient is unable to tolerate metformin because of GI problems. The patient gets regular genital mycotic infections, so SGLT2 inhibitors is not something she is willing to try. This is a small little lady. So my question is, what next? Shomit. Okay. Acha, Shomik, okay, fine. I had something very, okay, fine, Shomik, you start off.
So this patient has, I would say, a few concerns. One is that this looks like, since she has hepatomegaly, significant hepatomegaly, I would still like to believe that she has type 2 diabetes. Although type 2 diabetes is sort of a dustbin diagnosis, but she has type 2 diabetes. And given the duration of diabetes, which is nearly 20 years, and the fact that her A1C is 11 on supratherapeutic, I would say, dose of glimepiride with linagliptin, she has secondary oral anti-diabetic drug failure, although we could add on more, but 11 or 12 was the A1C.
Yeah.
So lean body habitus with secondary OAD failure, type 2 diabetes, looks like a patient where we could add insulin for now, stabilize things, and then take a call as to what to do next, one. The other issue is that she has severe anemia, which is also with normal renal function, which is also a cause of concern. So that needs proper investigation. There could be something underlying which we are missing.
Would you admit this patient?
Possibly not admit, but put her on insulin, investigate the anemia, and then take a call when she comes, say after a week, with somewhat better glucose control and some basic hematological tests.
Okay. Now, if I just take it away from this fact that, this patient is slim or very thin, but she has hepatomegaly with fatty liver, aren't we looking at bad MASLD as well? Yeah. So why not a GLP?
So again, I would rather look at the FIB4 if possible. But given the fact that she has severe anemia, she could be having some underlying hematologic disease as well. So the FIB4 could be erroneous. If available, a fibroscan could be helpful. But again, first I would stabilize the blood glucose level and take care of the anemia, and then look at the liver and other comorbidities. Those two would be my first two priorities.
Okay. Nilanjan?
Yeah. Here, of course, I would never consider a GLP-1 analog at this point of time. As Shomik has said, I will control the glycated hemoglobin. It's 12 plus with a fasting hovering around 300. So ideally with an MSI, her body weight is less. What is there any anorexia, any other cause of it? Whether she has gone into cirrhosis itself, where I think GLP-1 analogs wouldn't have much of benefit because she has anemia, platelets is 1.6, and there's a massive hepatomegaly. We do not know about whether it's splenomegaly or not. There's any decompensated liver disease or not. So I think, as he was pointing out, we have to try and find out the cause of anemia. In the meantime, stabilize the glycemia with MSI, and then if there are no other complications, if there is MASLD without significant fibrosis, definitely a GLP-1 receptor agonist can be added, but again, her body weight
at a later stage.
Later body weight is 40 kg, maybe whether she has anorexia. We don't want to add to her, sufferings in the hope of saving the liver 20 years hence.
Right. Shomit, you wanted to say something?
I will just dwell on one parameter, is MCV. This is severe iron deficiency. I won't be surprised if there is GI bleed from cirrhosis. I would go for an occult blood, definitely, stool for occult blood, to see whether that is happening or not. So workup of the anemia and the liver part, and insulin, I think.
What sort of somewhat reassures me is that she has a hepatomegaly. So usually in cirrhosis, the liver is shrunken.
Even with high blood glucose and this level of hyperglycemia, she can get hepatomegaly.
She can get hepatomegaly, but with cirrhosis, usually your liver gets shrunk. So hopefully she has not developed cirrhosis. Again, her platelets are 160, 1.6. So
Yeah,
you expect lower platelets in someone
and
with
she doesn't have a
cirrhosis.
transaminitis. So her FIB4 score, I suspect, will be normal. I didn't do it myself, but I think.
In advanced cirrhosis, your AST/LT might even, because
Come
there's
down.
no cells to generate. Platelets are good, yeah.
Any questions? Any kind of thoughts?
Liver big, if you have a caudate lobe thing, so it depends where is the 4 centimeters.
Okay. I'll put it to the August panel, but I personally wouldn't use GLP at this point at all.
12 HbA1c cachectic patient, 12 A1c, first is always insulin stabilized, then.
Any other question? Yes.
I wouldn't. I'll just hand it
It would
over.
be a complete waste of time. Saroglitazar is a drug which has no evidence backing it. I think we should try and avoid it at this point of time.
So I think we can ask the question, after stabilizing with insulin, do we consider pioglitazone?
Yes, why not? Pioglitazone? Any takers?
The only issue is if she's postmenopausal, I would avoid it for the risk of fractures. Otherwise, it could be a good choice.
Okay.
Anemia,
anemia.
hemodilution. So again, if we still, but here we have to look at the GI tract well. Not only cirrhosis, but she could be harboring an ulcer or even a malignancy.
Absolutely.
They are more common in patients with diabetes.
Absolutely.
Exactly.
Any other questions or any comments? Right. So we'll move on to the next case. This is all seen in one clinic, and I thought it would be interesting. So this is a 32-year-old lady. She's had amenorrhea for 6 months, knee and heel pain. She tells me that her partner tells her that she snores. She has weight gain. She's shortness of breath on exertion. She can climb up about just 1 or 1.5 flights of stairs. She has a family history of diabetes and coronary artery disease. Her father died at the age of 48. She's a smoker. Since she has had any anemia, she basically is in a same-sex relationship, so she declined a pregnancy test. She's on a PPI and a domperidone for her GI symptoms, which she has from time to time. She's on Lubrijoint. I don't know exact chemical composition of that for her joint pains. And she studies from escitalopram. I noticed in her notes that she had been advised CPAP, but no sleep study was documented. Her waist circumference is 110 centimeter, Shomit's favorite clinical examination. 155 centimeter, 91 kilos. So if you just double it, weight by height, I think it's more than 0.5. 110 by 70, pulse 90, blood glucose, impaired glucose tolerance, transaminitis, platelet a little low, LDL elevated, TSH 1.75, creatinine 0.6. She has F2 on FibroScan. This is the FibroScan that is done by all the pharma companies. ECG within normal limit, and she has an echocardiogram, which is CLVH, concentric LVH, 32 years age. What next? Shomit.
So I think this is typically what once upon a time we used to say metabolic syndrome. It has probably all the aspects of it. Amenorrhea, obviously, you said one issue you have closed down. I do not know whether you're also looking at PCOD or not.
I don't know. She has 6 months of amenorrhea.
So, and MSLD is there. If you do a simple stop bang, I think that is good enough. No need of a sleep study. And that will be positive here, probably more than 3. So this is an OSA. Obesity is there, liver enzymes elevated. F2, I will not, as gastroenterologist taught us, if it is not an EcoSense machine, I will not accept the report. It has to be from EcoSense with the proper T and CAP values. But even if it's F2, it's an intervention zone, so we have to intervene here. This patient is ideally suited for a GLP-1 therapy. Even if the patient is pre-diabetic. It's not from a diabetes perspective. From a metabolic perspective, if I think that the liver is most important, then you see by recommendation it is semaglutide. If I think OSA, then the first line is tirzepatide. See also osteoarthritis. So 2 points are going towards semaglutide more than tirzepatide.
I think it's logical to think of semaglutide based on evidence than tirzepatide, because just because OSA, it's presumed that if you lose weight with an incretin, even with semaglutide, there would be some benefits. So she is a good candidate apart from therapeutic lifestyle change of some sort of pharmacotherapy, and that may be an injectable incretin like semaglutide.
Some data on PCOS as well with semaglutide as well.
PCOS is also there. And of course, we have to work up for the PCOS. You do whatever, there's a transabdominal or transrectal ultrasound or transvaginal, if that is done, and the hormonal workups need to be done, and address the PCOS. If she wants periods, of course, at 32 years, she would want cyclic bleedings, so that has also to be addressed.
And also for bone protection with this.
For bone protection, endometrial health also.
Yes. Shomik, any further comments?
No, so osteoarthritis, as Dr. Shomit Ghoshal also said, she has clinical obesity. So obesity with possibly OSA, osteoarthritis, and clinically significant liver fibrosis. So SEMA more than tirzepatide. We are talking of the anti-obesity doses.
Also HFpEF possibly, shortness of breath on exertion with structural
CAD,
defect.
underlying CAD as well.
So I
the
think
SELECT trial.
SELECT trial. I think this is...
We are yet to get data in non-diabetic obese from tirzepatide. So again, one more factor in favor. She has CAD. One more factor in favor of semaglutide here, 2.4 milligrams.
Yes, so there's a structural abnormality. Any questions or comments from the House? Any comments? We'll move on. It's getting on to dinner time. So I'll show you. This is the last one, and I thought I had addressed this with Shomik in mind. Saw me 1 year ago, 50-year-old doctor, obese type 2 diabetes, started oral semaglutide with an HbA1c of 9.8%. Therefore, telephonic discussion, sharp weight loss and abdominal pain. I asked her to stop the semaglutide. She had an ovarian mass. It was told that it's benign, but the ovarian mass contained thyroid tissue. This is a doctor telling me this, that I can't remember the biopsy and I don't have the biopsy report, but it was a benign adnexal mass which contained thyroid tissue. And to me, the only thing I could think of was trauma. She's clinically well, not thyrotoxic, but since last year she has lost 19 kilograms in body weight. Has been off oral semaglutide now for 6 months, hasn't gained weight. A1C is 5.6% on no medication. Emaciated, and she was having some tests done. She had a TSH which was 6.5. So no thyrotoxicosis. And ultrasound 1 centimeter left-sided thyroid nodule, TIRADS 3. I have asked for an FNAC. What else would you do? Shomik, all yours.
Can we go back to the patient?
Yes, sure.
So with TIRADS 3, again, if the size is 2.5 centimeter or more, then we can go for FNAC directly. 1.5 centimeter or more, we can do a follow-up ultrasound. So that part is settled.
Do you think I'm wrong in asking for an FNAC?
So if this...
It contained thyroid tissue.
No, this was the thyroid nodule.
Yeah, but the ovary contained thyroid tissue.
So that's a struma ovary, which...
But not toxic.
But not toxic. So her TSH is 6.5. So I think regarding the thyroid part, we can sort of delay things. There's no hurry there. The concern here is 19 kg weight loss, despite being off semaglutide for 6 months.
6 months.
So again, just like in the first case, whether there's something sinister underlying, whether we are missing something, sharp weight loss, abdominal pain. So again, look at the abdomen carefully whether we are missing something else.
She
a
had
malignancy or
detailed
something.
investigations, left adnexal mass, ovarian. In fact, the surgeon actually left her uterus behind. They just took her ovaries out, didn't
And
take
the histopathology showed thyroid tissue.
This is what she said. I have not personally seen it. This is exact replication. She said it was a benign mass, but you know something, jano to dada, amar ota theke ekta thyroid tissue chilo.
And the other thing is regarding weight loss, as we were looking at, as Dr. Shomit Ghoshal was showing us phenotypes, we need to ask her whether it's intentional or unintentional.
She's not trying to lose weight, but she's definitely lost her appetite totally.
Unintentional weight loss.
Unintentional.
So without a GLP-1, suddenly if you lose appetite, that's
and 19 kilos.
That's an aberration from a normal physiology, which whenever you lose weight, you always gain appetite, if you are not on any therapy from outside. So that needs further investigation. Whatever be the cause, it needs further investigation.
So does this, Nilanjan, you being the senior most...
So one more thing is whether she's suffering from depression, anxiety, depression, or things which... A psychiatric part also needs proper evaluation, because as you said, she has investigated the abdomen thoroughly. Imaging has been done and all these, and possibly hematology has also been looked into. So
it's very interesting you say that, because I found it very strange that a doctor doesn't come with a histopathology report. You know, you would expect a doctor to have all the reports ready.
So whether there's a background psychiatric problem that we are
that
dealing
is also
with.
something
that also needs to be looked
thought
into.
of. Nilanjan, you being the senior most amongst the panel, does this not worry you about GLP-1 therapy? That, you know, weight loss takes place and we might be missing things which we attribute to GLP.
Yeah, that's a very practical thing, because we are being taught to see weight loss, to assess weight loss, and we are taught to be happy. The more the weight loss, we are taught to be happy as a physician, and this will translate into patients. And many a time there may be treatment failures. So if we could achieve it, but we have to keep in mind that there may be other causes, extraneous causes. Here, as Shomik has pointed out, there may be something else, maybe some problem in the ovary, some GI problem, some malignancy, some chronic infection that is being contributing to this unintentional weight loss. So we have to be pragmatic, as in any patient, even so in a patient with an incretin analog. And if the weight what you expect, that is, it's a very rapid weight loss, and whether there are other telltale features, then we have to think of it. For example, if the starting body weight of a person is 100 kilos, how much do you expect? Around, at the best, 20-25 kilos weight loss. The average is 20%, which sets appetite, 20% plus. So that makes it, say, 20-25 kilos. But if suddenly the weight comes down from 100 kilos to the point of she becoming emaciated, you have to think of some other pathology, and this cannot attribute to that GLP-1 analog. Of course, if that happens, we have to also think of stopping the GLP-1 analog and then re-evaluate. One cannot go on, means in the face of weight loss, just because it will be giving cardiovascular benefits, it will be giving benefits on sleep apnea, you continue with it, there should be a continuous audit.
I think that's a very important take-home message that comes from Nilanjan.
So it's a real life event. So in this doctor, the semaglutide was stopped, say 6 months back, but
she stopped it on her own.
But she was still losing weight. At NRS, we have had an incident where an ophthalmology professor, I think you remember, was put on a GLP-1 by an endocrinologist, not either of us, but another endocrinologist, and he kept on losing weight and had loss of appetite. It was attributed to the GLP-1 receptor agonist, and it turned out to be a pancreatic carcinoma. And he lost his life. So there could be something sinister underlying with the same sort of loss of appetite and weight loss.
Again, whether that is due to the GLP-1 analog or not, that's a secondary.
Too short a period of time.
Mask the symptoms.
Yeah.
That's a secondary issue, but we have to be,
aware.
alert, be aware that some other things, especially in an elderly individual who is having diabetes, may have some other chronic infections or chronic malignancies that can attribute to that.
Shomit, HbA1c has come down to
Yeah,
5.6%.
that's because of the weight loss.
That's weight loss.
So
But
weight
you
loss
see,
cures diabetes.
so 7 days half-life, the drug will be washed off your system by maximum 5 half-lives. So after 35 days, you don't expect any effect of semaglutide. I might sound again a little bit anal, but severe abdominal pain, severe emaciation, losing weight. I will again have a look at the hemoglobin, probably have a look at an ESR, probably again go for a stool for occult blood. If possible, maybe an endoscopy in this particular patient.
Okay, any questions or any comments? Sorry, sir? Malignancy. Yes, we are looking at that. Yeah. Anorexia nervosa.
Unlikely at this age.
So it depends on how the patient comes to you. If the patient comes to you with the complaint that she is losing weight, it's not possibly anorexia nervosa because they have a body image disturbance. They don't consider themselves to be thin. But if she is concerned that I am losing weight, then there could be something else.
Okay. Any other comments or questions? Thank you, ladies and gentlemen, for being such a wonderful audience. We've had a wonderful discussion and looking forward to see you again tomorrow. Thank you very much.